Dr. Naza, if you want to start, you can go ahead.
Okay, sounds good.
Thanks.
So today we'll talk about kidney stones and just go over some basic stuff that might be helpful for you when you come across a patient, what basic evaluation you can do, and also look at, in general, how kidney stones are evaluated. So today we'll talk about different types of kidney stones, different metabolic disorders that are associated with kidney stones, some imaging and investigation that you can do, and prevention and treatment as well. So if you look in general, for acute abdominal pain, kidney stone is not the first diagnosis. The most common cause of abdominal pain is constipation, and constipation is again a clinical diagnosis. Sometimes people will obtain a KUB to confirm the diagnosis, or in worst case scenario a CT scan when they think there is a acute abdominal or intestinal obstruction. So in that case, then you might incidentally find someone have kidney stones. If you look at least in the last decade, there is definitely a rise in the incidence of pediatric stones. It's almost up to 7.2 to 14.5 per thousand person years. And that is again on the rise. And this was just from one single study, one county study in Minnesota. And if you look in general, there was a study that was done in the last 10 years. One in 685 pediatric admission is because of kidney stones. And the cost burden of diagnosis of kidney stones and treatment is quite a bit. It's almost $2 billion that was spent in the year of 2001. Again, compared to adults, the incidence is much lower in children. One in two adults is suffering from kidney stones in America. And if you look, the total incidence is again, here, one second, let me move this. Oops. Let me go back. So 1 in 10 population and male to female ratio is 2:1. The other thing that we need to remember is there's almost 50% chance of recurrence of kidney stone in the first 10 years after the first stone. And in US, the incidence is much higher in boys, more so in the first decade, girls in the second decade. Kids with urinary abnormalities or UTI have higher incidence. Caucasians tend to have higher incidence than African Americans, so there may be some genetic predisposition there. And then, of course, geographical area do matter. So, Northern and Central America, Turkey, Thailand, these are all areas that essentially could be because of the water source, can also be the reasons for higher incidence of kidney stones. Uh, why do we need to know about kidney stones? As one, we definitely, it's a chronic we have to treat it as a chronic disease. The second problem is the with the opioid epidemic, more and more people with kidney stones are getting prescribed pain medications. And this is a study that was done just comparing people older than 65 and people in their productive age between 18 to 65. The incidence of opioid prescription for kidney stones has definitely on the rise. Body weight, and then with that also goes the fact that in the last few decades we have seen increased incidence of kidney stones because of the obesity rate. So there is a definite correlation between obesity or body weight with incidence of kidney stones. This is again a study that was done, showed the higher incidence of uric acid stones in obese patients compared to those of who were normal weight. So to come back, we have to remember the concept of how kidney stones form. So urine essentially is water with all the salts and waste products dissolved in it. So whenever there's an imbalance between these two things, either if there's low urinary volume, which comes from water you drink, or higher concentration of salts or compounds that can precipitate and form stones, then you can form kidney. Then essentially it's a perfect combination to form kidney stones. It could also be because you have lower levels of certain substances we call stone inhibitors that are naturally present in your urine that can also lead to stone formation. So The way the stones form, essentially they form like small little crystals. They form that form in the small collecting ducts. Eventually they become these randall plaques at the tip of the medullary pyramids, and then eventually as time goes as they break off and migrate into the pelvic ileal system. So you need to have multiple factors that contribute to it. One is environmental factors, which would be, your water intake, your diet, genetic reasons. Some people are genetically predisposed to it. Urinary concentration of these crystallization of products, uh, low concentration of stone inhibitors, and then certain proteins, and then also this concept of nanobacteria. So people have looked at how kidney stones essentially form. There's a concept of nanobacteria. So these are small little particles around which the calcium oxalate crystals eventually deposit, and then eventually these crystals join together, form plaques, and then ultimately kidney stones. So I was talking earlier about stone inhibitors. So we know most of the salts that are in the urine form stones, but there are also certain salts that are in the urine that actually prevent kidney stones from forming. And normally, these are things that are like citrate, magnesium, pyrophosphates, Tom protein, which is a uromodulin, uropontin, and nephrocalcin. So these are all naturally appearing substances in your urine that actually prevent crystallization. Citrate, for example, is something that comes from the diet, what we eat. Most of your, we'll go over products or like food items that are high in citrate. But essentially, what it does is it alters the pH and sometimes prevents certain forms of kidney stones from crystallizing. So this is just an overview. So first, citrate prevents supersaturation, meaning it prevents the combination of, for example, calcium to oxalate. It prevents the nucleation and growth of the kidney stones, and then it also prevents the aggregation, ultimate, exposure of these kidney stones, and basically just detachment of the kidney stone from the plug. So citrate is essential in all these different steps, and it basically prevents kidney stones from happening. So a Mayo study that was done in the last like a 10, 20 years ago showed that there is at least one identified risk factor in all the kids that are affected with kidney stones. And there could be metabolic abnormalities like hypercalciuria, which basically means high calcium in the urine, hyperoxaluria, which is high oxalate in the urine, high uricosuriia, which is high uric acid in the urine, or low citrate, hypositraturia. So of this, most common is again hypercalciuria, hyperoxaluria. And these are all idiopathic, meaning there is no underlying metabolic disease that is contributing to it. And in up to 19% of the patients, also urine infections was found to be a reason for kidney stones. So we know that kids with abnormal urinary tract systems are especially at high risk for kidney stones, mainly because of urinary stagnation. And then the longer the urine stagnates, then the urine undergoes some metabolic changes, most commonly alkalinization of the urine, that also can precipitate certain stones, for example struite stones, calcium phosphate stones. So in this, compared to a case series from UK, again in UK 53% of the kids had some metabolic abnormality as compared to 93% in New York. So there could be a genetic reason for it, or even a epidemiological reason for why there could be more kidney stones in certain country or certain geographical area compared to the other place. So, if you look at all the causes of kidney stones, there's a very high risk that these are things that are heritable. Meaning, if you have a family member with kidney stones, the likelihood of you having a kidney stone is also high. And this could be, again, genetic reasons, as we mentioned. If you look at each and every of those causes, for example, high calcium in the urine, high oxalate in the urine, pH of the urine, different things that are present in the urine, there's definite association to genetics. Coming to the different types of kidney stones. So calcium stones are the most common stones. And calcium binds to two things. One is oxalate or phosphate. So different types of stones, you have calcium oxalate, triple phosphate or true white stones, calcium phosphate stones, uric acid stones, cysteine, then mixed stones, then xanthine stones, again very rare, and then in some cases, in patients with can have bile and uric acid as well. So signs and symptoms, most common presentation of a kidney stone would be a colicky pain. So a sudden onset of, one-sided flank or back pain. Most of the time, this pain is very severe and intense. If it is migrating, the pain can radiate from the flank to the groin. Sometimes kids may also tell pain at the tip of their penis, like when they're especially peeing. Then there could also be other signs or symptoms like nausea, emesis, hematuria, so gross hematuria, um, and sometimes even microscopic hematuria. It is very rare to have someone with kidney stone and not have blood in the urine. And then lastly, yeah, and then fever. So if you have a patient with symptoms that sound like kidney stone and they are presenting with fever, then be worried about pyelonephritis or some form of upper urinary tract infection. The reason being, if the stone has been obstructed for longer and they have developed an infection, that could present like pyelo. So essentially, when you have a patient presenting with kidney stone, a thorough history and physical examination is definitely needed. So you're going to ask questions about, what other systemic conditions they have, chronic illnesses, are they on chronic medications, what are the list of medications, do a complete physical exam, try to see if there are other abnormalities that can are present. For example, even in the history, ask for history of fractures, ask for history of diabetes, things like that, chronic steroid use, for example. And then once you have an acute presentation, your focus should be on what is needed at that time. So if a patient is in pain, you will give them pain, medications, relieve their pain. Next step is do some radiological assessment, could be a KUB or a CT scan. If you look, CT scan is the best test to diagnose kidney stones. But again, you have to also think every time you have a patient with kidney stones and you're doing CT scans, that is a lot of radiation exposure. And then, of course, the urine analysis. The way urine analysis help is you will see blood in the urine, or second is to also rule out infections. Once you have all this, during an acute presentation, the focus is mainly on the patient. Once the acute presentation has resolved, then you will focus your attention on the stone evaluation. If you're able to retrieve the stone, send it for stone testing. If you're not able to retrieve the stone and the stone is lost, then you may have to do a 24-hour urine collection that we'll talk about. And this has to be done after the acute presentation. The reason being, typically when you do testing for stone, you have to do it when they are on their ideal diet. So if someone is in pain and not really consuming food, and you do a metabolic assessment, it's going to show what their intake is at that time. It doesn't necessarily give you an idea of what could be the reason for kidney stones. So typically we focus on their testing once the acute episode has resolved. And also in the history, very important to know is if these patients are patients with chronic UTIs. So all your neurogenic bladders, kids with urinary retention, those are patients that you would like to know, basically to find out if they have true white stones. So those are a few things. Then in the history, also important to ask is the medication history. So certain medications, these are again medications that are not commonly prescribed, but some of them are. For example, your antacids, magnesium, aluminum oxide, hydroxide. Again, very rare nowadays, but in some countries, I know this is still something that is used quite often. Carbonic anhydrase, again, not in a patient who would be otherwise well, would have some other underlying factors. Those are things that you can ask. And then allopurinol, for example, again, a lot of cancer patients, go undergoing chemotherapy, calcium supplements. So there's always this thought of, someone who's on multivitamins or calcium supplementation is at higher risk for stones. Yes, if you are consuming calcium at a very high intake, then yes, it can cause kidney stones. But in general, what we find is it's not for people who, for example, the question the parents will ask me is, my child drinks a lot of milk, is he at risk for kidney stones? And again, milk is something that most kids, younger kids do drink. Sometimes a couple of glasses of milk. I have kids who even say that that's all they drink throughout the day, they don't drink any water. So it all depends on the intake. Calcium pills or tums or your vitamin D supplements definitely have higher amount of calcium. So you have to look at the daily required intake, DRI intake of calcium. And if it is more than 2000 milligrams, then yes, it could be one of the factors causing kidney stones. For kids who have kidney stones and they drink milk, I do not tell their parents to restrict their milk. All I tell them is to give them normal intake. So if they are doing more than a few glasses of milk, I would tell them to cut it down, but not to completely eliminate it. And we'll talk about why intake of calcium is also very important in prevention of kidney stones. Next, coming to the investigation, as we said, a simple urine analysis with blood in the urine or even crystals in the urine could be a good test to start off. If a patient has fever, then yes, definitely obtain a CBC. Look at the white count to see if they have any infection. A BMP, again, to make sure in case of acute obstruction that the patient doesn't have, like an obstructive uropathy causing, creatinine to be elevated and stuff like that. It's not uncommon when kids come in with acute kidney stones, they are not well hydrated and they're kind of dehydrated. You may see the BUN and creatinine slightly elevated. And if you do notice that, once you have started hydration, then repeat the BMP to BMP is basic metabolic panel, to basically check if those parameters do improve with hydration alone. Um, then we talked about KUB. Plain X-ray of the abdomen would be helpful. Less radiation. Again, this is when you have a stone that is radio opaque that you may see this, and it also depends on the location. So and the size. So sometimes if the stone is right overlapping over over a bone, for example, the pelvic bone structures, then you may not see the stone very well. So KUB is a good place to start with. And this is where most of the times when kids come in with abdominal pain, they're getting KUBs and they find incidental stones. Then the next best test would be a low dose non-contrast CT. Um, a helical CT would be, most diagnostic if you are looking for a stone. IVP, intravenous pyelograms, again, this is become almost ancient right now. We don't do this as much because of the availability of CT in most of the hospitals. And then retrograde pyelogram as well. Again, it's too invasive and it's not done routinely. We tend to do it in our patients who have, for example, very big, huge white stones who need, those stones to be broken down, and it's done through the urologist with a cystoscope, and it's both basically done both for diagnostic and treatment purposes. So colic is because when is the pain that they experience when the stone starts moving. So there are three junctions in the normal anatomy where typically stones can get stuck. You have to remember the size of the ureter is also depending on the size of the child. So a typical 2 to 3 millimeter stone is something which we would consider a small stone, would pass easily. But again, there are certain narrowings in the urinary tract where these stones can even get stuck if they have stagnated for a longer time. So one is the uretropelvic junction, where your ureter comes out of the kidney, and then there is a slight narrowing before it becomes the abdominal ureter. Then the pelvic brim, it's where the ureters cross over your pelvic bones. Again, there could be a slight constriction area there. And then lastly is the uretrovesical junction, when the ureter inserts into the bladder. So these are potential areas where the stones can get stuck. So if you have a patient who has come in with abdominal pain and you have a KUB, then you're looking at these particular areas to identify if you see something like a stone. Um, Again, a urine analysis, you see this a lot. A lot of times patients get referred to us for calcium oxalate crystals. So remember, when you see amorphous crystals or crystals in the urine, it doesn't necessarily mean a person has stone. But if a person has history of stones and has crystals, then it makes more sense. And the reason for that is, even a normal person, if they are not well hydrated, and for example they have acidic urine because they eat meat, and they have lower urinary pH, even in that circumstance, even with normal calcium and oxalate content in their urine, those things can crystallize. Or if you have a patient who gave you a urine sample and the urine sample was sitting on the table for like 1 to 2 hours, even then you can see some crystals. So calcium oxalate crystals is something that is commonly seen on routine lab tests. Not all of those patients need full stone evaluation. Is the patients who have had kidney stones or other risk factors, then in that case, then you would do a stone analysis, evaluation. Sometimes you'll see uric acid crystals, and this is again in acidic urine. Uh, for all these things, for to look at the crystals, the urine has to be examined under the microscope. So a very good lab technician who is aware of these crystals will tell you that there is specifically like uric acid crystals or cysteine crystals. The reason being, the urine has to be looked under under what do you say, different kind of light to identify these crystals. So they may report as just amorphous substance, and then you may want to go back and look at the urine yourself. So these are a few appearances that you can see in the normal light microscopy. So on the top left is your the hexagonal shape. These are struvite crystals. Then you have the coffin lid, which is the coffin lid is the struvite. The hexagonal is cysteine. The envelope shape, which is number C, is the calcium oxalate. And this is dihydrite. Monohydrite will look more like a dumbbell shape. And then you have the rectangular shape in the box E, which is the uric acid. It can appear both as rhomboid in F, or it can appear as rectangular. And again, these are translucent, so that's the reason why it may be hard for some people to identify them unless they're specifically looking for it. Uh, in the history taking, you're focusing on all these factors, for example, UTIs, voiding dysfunction, previous surgical procedures, especially for urinary tract system. Then you want to obtain if there is a family history of kidney stones. And as previously alluded, there's almost 75% of the children with kidney stone have one family member who has had kidney stone in the past. So it is very common. And then you look at other medical conditions like malabsorptive conditions, cystic fibrosis, myelodysplasias, immobilization, recurrent skeletal fractures that I mentioned to you, hyperparathyroidism, mostly primary hyperparathyroidism. And then other factors could be like prematurity. In prematurity, there are two things. One is you could have, nephrocalcinosis because of immature tubules, or could be because of use of fluoresceamide or Lasix, especially for their patients with chronic lung disease. They use this commonly, or even in cardiac patients where they use Lasix. Long-term Lasix use can also cause kidney stones. And then also in premature infants, you have to remember most of them are exposed to like a long-term TPNs, parental nutrition. They are also getting formulas that are very high in calcium and phosphorus content because of the fortification to give them more calories. So these could all be factors of causing kidney stones. And then we talked about a few medications that can cause kidney stones, but the other ones include like steroids. Long-term use of steroids can cause increased calcium losses from the bone, your chemotherapy drugs, anticonvulsants like, for example, Topomax. Topomax is something that's prescribed quite commonly, even for both for seizure disorders or even for headaches. Loop diuretics like furosemide, which we discussed about. Ketogenic diet. Ketogenic diet is used for refractory seizures. The problem with ketogenic diet, which is again now common even in other people who are trying to use this for like weight loss, very high in protein content. Protein is something that gets broken down into uric acid, one. Second is protein, also protein metabolism causes more acid generation. So you will have more acidic urine. So both are factors that can cause kidney stones. And we are seeing this quite often in a lot of patients. Then urogenital tract, abnormalities that we already talked about. So the other things that you have to focus also on physical exam is, for example, failure to thrive. So your distal RTA, type 1 RTA can cause hypercalciuria. Most of these patients will present with failure to thrive. So they will have problems gaining weight, short stature. Some of these kids can also have hypertension. Very rarely you may see rickets or even soft tissue calcification. But again, primary hypercalcemia, again, very rare. So we talked about all the radiological imaging. Let me skip over this. And then metabolic assessment. So as I said, we would postpone it until the acute event has resolved. Once this is resolved, the main thing is to first repeat the urine analysis, make sure the infection is completely cleared up if there was an infection to start with. Then you would do a basic metabolic screen that includes renal function panel, look at the electrolytes, calcium, phosphorus, magnesium, uric acid. You will also check parathyroid hormone level, vitamin D levels. And then next would be to do a 24-hour urine collection. So in the 24-hour urine collections, things that you will order is total urine volume. You want to know how much volume of the urine there was. And then measure all the things that cause kidney stones, your calcium, your sodium, potassium, magnesium, phosphorus, creatinine, pH, citrate, oxalate, uric acid, cysteine, and protein. And in here in America, we use a lab called Litholink, and that lab is really amazing. They actually do all the supersaturation calculations for us, tells us exactly like what would be the patient's diet, what is contributing to the kidney stones, and what things need to be changed. So these are the normal values again for different urine 24-hour studies. What I would like you to remember is, the spot urine calculation. So when we diagnose someone with hypercalciuria, the urine calcium to creatinine ratio should be greater than 0.2, and for infants greater than 0.6. So if you have a patient who has blood in the urine, has symptoms like kidney stones, and you want to know if they really have a kidney stone, you can do a screening test of urine calcium to creatinine. And if it is greater than 0.2, then be suspicious about it. You can even go ahead and do a 24-hour collection and measure the calcium. And if it is greater than 4 milligrams per kilo per day, then it's considered abnormal. And then you can always refer them to a nephrologist. But you don't have to remember all these numbers. But just remember, urine calcium to creatinine ratio, hypercalciuria, is a very common predisposing factor, and it's very common, at least in my clinic, I see up to 4 to 5 patients each week who have blood in the urine and high calcium in the urine, and this is something that can be easily treated. So these are all the things that we order on a 24-hour urine test, and then we'll go over the classification. So broadly, you can classify stones as calcium stones, which would be your calcium oxalate, calcium phosphate stones, oxalate stones, struite stones, uric acid stones, and then cysteine and other metabolic stones like xanthine and orotic aciduria. Again, this is very rare. We won't be discussing that today. Starting with the calcium stones, again, most common kind of kidney stones, almost 90% of the times it's a calcium stone. And the reason could be because either there's increase amounts of calcium, oxalate, or uric acid, or there's low amounts of citrate. Calcium oxalate stones actually precipitate in acidic urine. So if you have low citrate, then citrate can is one that causes alkalization of urine. So if your citrate levels are low, that may cause urine to be acidic, can also be a factor for calcium oxalate stones to form. And there are a number of environmental factors that cause increased calcium in the urine. One is you have decreased water intake, so lower urine volume. Second is increased sodium. So when you have increased sodium intake, you lose more calcium in the urine. And then third is immobilization. That can also be the reason why you have more calcium into the urine by just the bones getting leached out. And then medications like loop diuretics, where again you tend to lose more calcium in the urine. And then of course lastly, excessive amounts of vitamin D. All these are different reasons why you can have increased calcium in the urine. So once you have increased calcium in the urine, the calcium can bind to either oxalate or phosphate. But let's start with the main condition here, the hypercalciuria. So hypercalciuria accounts to almost 50 to 90% of the stones. And by definition, as I had told, urine calcium to creatinine ratio on a random specimen more than zero point 0.2, or on a 24-hour more than 4 milligrams would be a definition for hypercalciuria. And this is one of the factors for forming kidney stones, and common reason for microscopic hematuria in children. And you treat the underlying cause. For example, if it is decreased water intake, you fix the water intake. If they're on medications that cause high calcium in the urine, you change that. Or basically you reduce the salt intake, then that would be the treatment for hypercalciuria. um, Next is the things, the other medications that form calcium stones, your acetazolamide, amphotericin, antacids. Again, acetazolamide, it makes your urine acid slightly acidic. You have more calcium in the urine. Antacids, calcium or non-calcium based, again causes hypercalcium, like calcium stones in similar way. Loop diuretics, we also already talked about. Topiramate, Topomax, same thing. It alters the urinary pH and increases the calcium loss. It almost causes like a RTA, renal tubular acidosis, causing kidney stones. So the other way you can have hypercalciuria is also from increased intestinal absorption of calcium. If you have more calcium intake, or you have a patient who has intake of calcium supplements, then you will have more calcium absorption from the GI tract, and then increased calcium in the urine. Second would be also from the bone resorption. If you have patients with immobilization, for example, your cerebral palsy patient, quadriplegic patients, they can also have increased calcium in the urine. And lastly, increased calcium loss in the urine because of secondary conditions like renal tubular acidosis or medications. So this is just a normal, schematic of how calcium absorption happens. So for normal calcium absorption that happens from your diet, you need your vitamin D, active vitamin D. So vitamin D, along with your parathyroid hormone, will decide how much absorption of calcium happens from the GI tract and how much gets lost in the urine. So this is the so vitamin D is essential for calcium absorption. When in case of your urinary leak, you have more calcium excretion in the urine, and that in turn will stimulate more absorption of calcium from your gut, increase calcium resorption from your bones, and then increase parathyroid hormone to maintain that calcium in the blood. So when you lose more calcium in the urine, these are other ways by which your calcium is supplemented. So this is the reason why in a patient who has increased calcium losses in the urine, we do not stop their calcium intake. The reason being, if you stop the calcium intake, the only way the calcium in the urine will then come is from the bones. So in order to prevent the bone resorption, you need to have someone who has adequate calcium intake. Otherwise, the bones will get weak. And then, of course, there are other mechanisms by which you will lose calcium in the urine, and this includes a lot of inflammatory markers and stuff like that. which we don't have to go into detail. So essentially, with all these things, the main thing is there's a lot of calcium loss in the urine, and that calcium that comes from the biggest reservoir is our bones. And so studies have found that kids who have kidney stones actually have weaker bones. They have osteopenia. So that's the reason why restricting their calcium intake will worsen their bone disease, and bone will become weak. So we do not restrict their calcium intake. And same is true with adults. So adults who have kidney stones, there are studies that show that their bone density is actually much lower and higher risk for fractures. Mm, so apart from these causes of high calcium in the urine, there could be other monogenic disorders, and this is where this is inherited. So there could be a familial reason for it. A lot of times, when we have a kid with family history of kidney stones, there are multiple family members, including siblings, parents, uncle, aunts, sometimes even grandparents, who have similar forms of kidney stones from high calcium in the urine. And then, of course, environmental factors. If you look, one of the biggest risk factor right now we have is the high sodium intake, high salt intake. With all the processed foods that are become so common, fast foods, for example, very high in sodium, there's a high risk for kidney stones. Same thing with ketogenic diet. Not just for our seizure patients, but also people who are practicing ketogenic diets for thinking that that's a more healthy kind of way of eating. They are also at risk for calcium stones. Lastly, when you have a patient with hypercalcemia, ultimately they will develop hypercalciuria because of the increased calcium load that is filtered across, and then directly inhibiting the calcium reabsorption too. So if your calcium is really high in the blood, then your parathyroid hormone is suppressed. So then you will lose more calcium. These are other monogenic causes, like Fanconi syndrome, which is again your renal Fanconi, type 2 RTA, Dense disease, Bartter syndrome, your familial isolated hypoparathyroidism, again, very rare causes. Autosomal dominant hypocalcemia, your calcium sensing receptor mutations, Little syndrome. Little syndrome is something that we quite commonly see with hypertension. Pseudohypoaldosteronism, again, Gordon syndrome, very common, associated with kidney stones and hypertension. The second risk factor is hypocytituria. So as we discussed, urinary citrate is needed for in multiple ways to prevent stone formation. So if you have a patient with low citrate in the urine, then they are at high risk for calcium stones. So one is basically because it reduces the urinary calcium saturation. It prevents the ionized calciums from binding to each other. Then it also prevents the agglomeration of the calcium oxalate. And lastly, it also helps minimize the sodium urate then salting over the calcium oxalate. So different steps of the stone formation is inhibited by the citrate. So hypocytituria can also be genetic or could be because of diet. Main thing is diet. Citrate comes from diet. So there are fresh fruits and vegetables that are very high in citrate. So if a child is not eating a lot of fresh fruits and vegetables, then they can technically have less citrate in the urine. So what we do is if we know that that's one of the reasons or risk factors for the kidney stones, then we supplement it. And the way to supplement it is by using a medication called potassium citrate. The thing with potassium citrate is it has to be given multiple times, at least 2 or 3 times a day, and because of the potassium in the in that medication, they will need blood tests to monitor it so that you don't overdose and cause hyperkalemia. And then the main way to find out if a patient is responding is you check the urine pH. So if a patient had acidic urine prior to starting the citrate supplementation, then you want to alkalize their urine. You don't want to over alkalize their urine, but keep the urine pH between 7 to 7.5. That's the pH around which the calcium oxalate crystals won't form and the calcium stones will not develop. So important is also potassium in the urine. So potassium is something that is present along with citrate. So if you increase potassium in your diet, that also will prevent kidney stones. So these are common foods that are high in potassium. For example, apricots, avocado, bananas, cantaloupe, oranges, orange juice. When I talk about orange juice, it's mostly fresh orange juice rather than the store-bought orange juice, and we'll talk about it more. And then vegetables, your dairy products, etc. So the second form of kind of calcium stone is calcium oxalate stones, or because of hyperoxaluria. And in this condition, there is basically high oxalate content in the urine. And this could be from a couple of reasons. One is normally your urine oxalate is derived from your endogenous production, and 10 to 15% of what we eat, the amount of oxalate in your urine comes from what you eat, and the rest of it is actually endogenously generated. There could be mild hyperoxaluria tends to be idiopathic, could be secondary to increased enteric absorption. So if you have a fat malabsorption condition where basically you have excessive fat in the GI tract, it binds to the calcium. So then there is less calcium available to bind to the oxalate. So the free oxalate gets absorbed. And then secondary could be from increased diet. So there are a lot of vegetables that are high in oxalate. For example, spinach. Spinach is good, but then it's also high in oxalate. So if you are someone who's eating certain vegetables more often, then you may have increased oxalate absorption from your GI tract. High vitamin C. So again, a lot of times the vitamin C, people try to overdo it when they are trying to prevent, say, for example, flu. Right now with the coronavirus, a lot of people have increased their vitamin C intake. That could be one of the reasons. Vitamin C is also something that is used as a fortification. So a lot of your orange juices are fortified with vitamin C. Vitamin C gets converted to oxalate. So oxalate eventually, getting absorbed, binding to calcium, can form calcium oxalate stones. Um, Other conditions could be because of absence of anaerobic intestinal oxalate degrading bacteria. So oxalobacter is a normal commensal that's in your GI tract that helps break down the oxalate. So in certain kids with small bowel obstruction or even GI problems where they have bacterial overgrowth, the oxalobacter content may be much lower, especially cystic fibrosis patients. And this is one of the common reasons why they can develop kidney stones. And then lastly is if they have epithelial damage, especially when you have increased bile or free fatty acids, that basically causes inflammation in the GI tract, then you may absorb more oxalate. So these are certain foods that are very high in oxalate, like beets, spinach I talked about earlier, but your tea, sweet tea, beans, onions, cocoa or chocolate milk, very high in oxalate. So if it is apart from the mild hyperoxaluria, if it is moderate to severe, so this is where you start suspecting primary hyperoxaluria. And this is a genetic condition wherein either you have an enzymatic defect wherein you are producing excessive amount of oxalate, and there is basically two types: type 1 or type 2. Type 1 is because there's diminished activity of hepatic alanine glycoxylate aminotransferase. And eventually, what it causes is there's abundant oxalate production. All this oxalate will then deposit in most of your organs: liver, kidney, bones. Again, it's a very overwhelming disease. I have yet to see a patient of hyperoxaluria, but in this condition, the only way to treat this patient would be one, to either get them a liver transplant, because this is an enzymatic problem, and then maybe even a kidney transplant if their kidneys are already deposited with oxalate. So even with dialysis or using excessive water intake, it's very hard to get rid of the oxalate that's already deposited. Type 2 is again a rare condition. This is where you have a defect in the glycerate dehydrogenase enzyme, less severe than type 1. But again, these are also patients who would present with multiple kidney stones to a point that they have significant CKD. Again, a treatment for hyperoxaluria, if it is mild condition, you will do a oxalate restricted diet. If it is a fat reason from GI tract, for example, fat malabsorption or inflammatory bowel disease, the main treatment is based on the GI disease. And then beyond that, you can use, citrate. You can use potassium citrate. You can use calcium with diet. So, for example, we ask these patients to take Tums or antacid immediately after diet, so that the calcium actually binds to the oxalate, excess oxalate in the gut, and they poop it out rather than the oxalate getting absorbed into the blood and then binding to the calcium in the blood. So Tums or calcium intake with the diet would be one other way of treating it. And then in cases of primary and second primary hyperoxaluria, because it's a genetic disease or enzymatic disease, you can use pyridoxine as one way. Otherwise, most of these patients would need a kidney and liver transplant. The third condition that causes calcium stones is hyperuricosuriia. So hyperuricosuriia basically means high uric acid in the urine. So uric acid, one, it causes acidification of the urine that causes calcium precipitation. Second is uric acid can form the nucleus around which the calcium oxalate crystals then deposit. So that's also another mechanism. And then it also makes makes the calcium oxalate less soluble into the urine or the water, causing again calcium stones to precipitate. So best thing is again to basically find the reason for the high uric acid in the urine and address that, and basically use that as a treatment for those kinds of kidney stones. So pure uric acid stones are again very rare. We tend to see this most commonly in patients with some kind of malignancy. So wherein you have increase or excessive breakdown of cell products, and that causes the uric acid generation. And typically, the way you will get rid of these stones is you increase, their water intake. Um, I kind of lost my thought here, but yeah, so essentially these are stones that are radiolucent. So when you do an X-ray, unless they have calcium also along with these stones, if they are pure uric acid stones, sometimes you may miss it. And of course, we have different definitions of what is high uric acid in the urine. And then ultimately, you need to remember is whenever there's increased uric acid production, or you have isolated tubular defects or medications that cause uricosuric conditions. For example, your probenecid. Probenecid is a medication that's used that increases uric acid excretion into the urine, will also cause uric acid stones. And then lastly, if you have a patient with acidic urine and high uric acid, it's perfect combination for them to precipitate uric acid stones. Um, so most commonly, again, because of high dietary protein intake, purine intake, uh, you know, all the uric acid basically comes from breakdown of your nuclear proteins or nucleotides, and that's one. Second is cancer, high cell turnover. Other metabolic conditions like Leishmanians or glycogen storage disease, these are again rare causes, but again, you will have increased uric acid production that basically causes them to then have uric acid stones. Foods that also increase the causes of uric acid stones is alcohol. So alcohol intake very common. Thankfully, not so much in kids in our population, but in adults. Then meat products. So red meat, pork, lamb, high protein intake like that can also cause uric acid stones. And again, medications that are associated with uric acid stone, we talked about this ketogenic diet, your estrogen, for example, patients who are on estrogen supplementation. Again, those are all patients who can have high uric acid stone or formation of uric acid stones. So for uric acid, the main thing is again the low urinary pH is one contributing factor, and then high uric acid in the urine, and then the diet that is also contributing to it, and low water intake definitely is a perfect setup for them to develop uric acid kidney stones. So the treatment would be to increase water intake, uh, alkalinize the urine by using say citrate, and then third thing is to prevent the uric acid from decrease consumption, so you decrease the protein intake. So a perfect we say lithogenic diet would be low water intake, high salt intake, high protein intake, and then low calcium intake. So this would be a perfect diet for someone to develop kidney stones. So a non-lithogenic diet is exactly opposite of that. Again, these are certain disorders of increased purine production. Again, I won't go into detail, but you have your hypoxanthine, guanine, phosphoribosyltransferase transferase deficiency, which is your Lesch-Nyhan syndrome, and then glycogen storage diseases, tubular diseases, probenecid. We talked about how probenecid increases uric acid excretion. Of course, you know, other conditions like gout with high uric acid can also be the other things. So treatment, as I had already alluded, you basically increase someone's uh, water intake, you reduce the diet, alkalinize the urine, and treat them with those. And then if you have a condition where you have increased uric acid production because of say chemotherapy, or a patient has is on medications, then you may use allopurinol. So allopurinol basically then diverts the uric acid excretion into the urine, and it basically converts it into other products. So allopurinol is something that you can use in patients with uric acid, and I use this quite commonly in my practice. So ultimately, if you basically, just summarize, these are all the risk factors for calcium stones. One is low urinary volume, hypercalciuria, which is high calcium in the urine, could be from monogenic causes, dietary causes, medications, and then hyperoxaluria is either primary hyperoxaluria or mild hyperoxaluria just from intake. Vitamin C being the most common. Hyperuricosuriia is again because of metabolic conditions or even hematological or malignancies. And then hypocitraturia is where either because of low citrate intake or dietary deficiency or certain metabolic diseases. And the treatment for all these conditions would be first main thing is to increase water intake, uh, reduce the diet having oxalate uric acid, and supplement it with diet rich in citrate and potassium, or use medications like potassium citrate. So another thing that I failed to mention is in hypercalciuria, if the main problem is just calcium in the urine, then you can use thiazides. Thiazides are again diuretics that actually reduce the calcium content in the urine. So you can, if it's the only reason for kidney stones, then you can use thiazides. And if the main condition is just high uric acid, then you can use allopurinol. Again, these are less common stones, but I'll just briefly go through it. Xanthine stones, very rare. We don't see this often at all. Could be because of deficiency of xanthine dehydrogenase. And then because xanthine gets converted to uric acid uh, in normally, and it doesn't get converted, then those xanthine products can then be excreted in the urine. And again, they cause acidic urine, so they can precipitate. Most of the times it may appear like a orange or brown sediment on the diaper. So this is something that you will commonly hear from parents, that they saw a little stain on their in the diaper, and most of the time is xanthine. Again, it is a common condition in infancy or in young kids, and usually resolves on its own. But if it is present for longer, then you may need some that kid need to be evaluated. So even just normal dehydration, you may see the xanthine particles in the urine. So that's one. Secondary condition, Lesch-Nyhan. Again, in this, you'll have more history. So patient will have self-mutilating behavior, not only just stones, but they will have other psychiatric illnesses. So in that case, then you may want to look at either alkalizing the urine, or using other medications to basically treat the xanthine. Cystinuria, this is a condition that we commonly look for. It's an autosomal recessive disorder again. Almost 10% of patients with kidney stones can have cystinuria. And this is one condition where you'll have multiple family members with kidney stones, most of them again calcium stones. But when you do a 24-hour risk analysis, you actually find that they have cystine. So the main cause for calcium stones is actually cystine in the urine. And normally cysteine is basically an amino acid, which is a dibasic amino acid, and it doesn't get broken down. So they lack the enzyme that breaks it down. So what happens is they have high cysteine in the urine, which is again in an acidic urine, can precipitate and then form stones. The treatment again here is to use medications to alkalize the urine, or prevent the diet that contains cysteine. Again, it will be very hard. We actually have a medication for this. So cysteine appears like a hexagon, and the treatment for this is called theotropin. So if you go to the end here, theotropin is a medication that is available that can actually prevent the cysteine from crystallizing. The thing is, this medication is not used in very young children. I think the minimum age is you have to be 6 years old. Very expensive, has to be used multiple times in a day. Other things that we use is D-penicillamine. Again, this is something which is almost again ancient medicine. I have never seen anyone prescribe this anymore. But again, there are more complications with D-penicillamine than to use it. So Thiola or Theotropin is probably the most commonly used medication for cystinuria. So what it does is basically, you know, it replaces the two cysteines that are bound by the bond. It replaces it with thiola, and essentially what it causes is it doesn't let them join together and form a stone. So if you have cysteine, then they will all accumulate and form a stone. Whereas in this case, the thiola actually repels them apart, so then they don't precipitate. And then this is another condition. So if you have a kid with urinary tract infections, your urinary stasis kids, these are again kids who commonly develop kidney stones. They develop this triple phosphate stones or struvite stones. And the reason for this is urinary stagnation is one. Urine gets more concentrated. They may have infection from these urease splitting organism. When these organisms basically cause increase carbohydrate bicarbonate content or alkalization of urine, then all the magnesium and phosphate will precipitate. So the treatment in this condition would be to eradicate the infection. So treat them completely by either using prophylactic medications or even treating them for UTI, eradicating the organism, and then increase their water intake and increase their urinary drainage. So if they are on intermittent catheterization, either do that or place overnight Foley's so that the urine doesn't stagnate. Most of the times these stones are very big, they're huge, they can form like bladder stones or even in the kidney, and in very severe cases it can completely shut down the kidney. So these staghorn calculi, for example, they will completely block the kidney and cause kidney failure. So in these patients, essentially there are preventive measures of are the best ways to treat it. And once you have a kidney stone, then it has to be removed surgically. So that's the coffin lid shape for the struvite stone. Um, as I said, for infection-related urolithiasis, the main is to sterilize the urinary tract, one. And it can be sometimes hard when, especially if those kids are colonized. So remember that. And then the second thing is to, irrigate the bladder, make sure they're drinking lots of water, draining their bladder more adequately, and other things, which again, I don't use this in our practice, but there are things like acetohydroxamine acid, which is urease inhibitor, that can be used. And of course, the best thing is for you to refer them to the urologist to make sure that their bladder stuff is taken care of. So to summarize, if you have a patient with kidney stones, the main thing is you want to do a basic workup. Once the kidney stone has passed, then you will do a chemical analysis. Either if you retrieve the stone, do the chemical analysis of the stone, find out if it's a cysteine stone, uric acid stone, struvite stone, and then do the complete urine, 24-hour test and plasma test or your blood test. The main thing is also to obtain a good nutritional or dietary intake history. So ask them what their typical foods are for breakfast, lunch, and dinner, how much milk they drink, how much water they drink, how much salt content is in their food. Those are things that will help you then evaluate if this patient can be treated with diet changes alone or you want to do medications. So this is just I wanted to show you of how the stone testing report looks like. So I told you about the litholink, and in this patient, as you see, this patient has undergone 5 sets of urine tests, and it tells me starting from 2006 to 2008, the risk factors of kidney stone has definitely changed a lot. And whatever is in green is good, yellow is borderline, orange and red is not good. So this report is very easy to to read, because then I can focus on whatever is highlighted in red and see what could be the cause of kidney stones. For example, if you pay attention here, in in the year 2007, the middle column, this patient had very high calcium in the urine, high oxalate. So if the patient definitely has increased risk for calcium oxalate stones. And if you look, the pH of the urine is 7.3, which is good. So the calcium oxalate stones precipitate in acidic urine. So 7.3 is good. Citrate levels looks really good, 12. Normal citrate, we say anything above 800 is good. So this patient, the best way to treat this patient is, one, increase their volume intake, urine volume by increasing water intake. Second thing is you can use a thiazide. And then third is you can use oxalate, decrease the oxalate content in the food, or use Tums with diet. So you're using thiazide to reduce the calcium in the urine. You're using calcium in by mouth to basically bind to the oxalate in the gut, and then reducing the oxalate absorption, and then increasing the volume or water intake. So that would be a best thing to do here. I actually don't remember exactly what we did for this patient, but you see the repeat test does definitely look better. But in that case, the uric acid level went up, and that may be the reason why the urine pH now is low. So then you will ask this patient to reduce his protein intake. So this is how you look at these tests, and then look at the diet history, and then compare if those are things that you can modify. So, calcium phosphate stones, again, these are stones that precipitate in alkaline urine, unlike calcium oxalate, which is acidic urine. The condition is, again, if you have hypercalciuria or you have hyperparathyroidism causing hypercalciuria, then you can precipitate calcium or phosphate stones. Pure calcium phosphate stones are kind of rare. Usually, you will see a mixed stone. You will see calcium oxalate and calcium phosphate stones, like mixed stones. And for calcium phosphate stones, the best thing is, you can't acidify the urine. All you can do is increase water intake. One, dissolve the stone. Second, you can reduce the calcium, so you can use thiazide. So beyond that, there's not much you can do for calcium phosphate stones. So the main treatment for stones is water. So water is very, very essential. We say that increasing water intake alone will reduce your risk for kidney stones. This was a study done in actually adults who had kidney stones. They say that the minimum water intake up to 2.5 liters, 3 liters is essential. So you have to have at least 2.5 liters of urine volume to achieve low risk for kidney stones. So we know that just increasing water intake will reduce your incidence by almost, or recurrence rate by more than 50%. So water intake is going to be essential. So again, kids, I'm sorry, not kids, adults who had stones, 5-year follow-up, the time for recurrence of stone was reduced by half in people who had more than 2 liters of urine. Calcium intake, we talked about this, why it is essential not to prevent or like reduce calcium intake a lot. So you have to maintain your daily requirement, in daily recommended daily intake, which is around 1,000 to 1,200 milligrams of calcium a day, which is at least 2 to 3 daily servings. The reason being, if you restrict the calcium in diet and you have increased urinary loss of calcium, then it's going to cause your bone resorption. So in order to prevent that, you need to have normal calcium intake. Again, if you look at most patients who have stones, their calcium intake is much lower. So uh, the lower the calcium intake is, the higher the risk for stone formation. Third thing is to restrict the salt intake. Salt is a very common factor for kidney stone formation. I think I've gone over my time, but essentially you need to remember is less than 1 teaspoon of salt, which is less than 2.3 grams of salt a day, is important. And this is again a study to show that higher urinary sodium, higher the risk of urinary calcium, and then high kidney stones. Citrate, we recommend 4 ounces of citrate containing juices. Reduce your kidney stone formation by more than 80%. So this is something that's very essential. And then, of course, fresh fruits and vegetables. So higher your urinary content of potassium and citrate, the lower the risk for stone formation. So last thing I would like to kind of highlight is citrate is very high in fresh fruit, lemons and limes, rather than your lemon juice bought from the store, including orange juice. So we recommend fresh lemonade made at home, 4 ounces a day for citrate consumption. Protein, of course, less protein intake, red meat, eating in moderation, eating it less frequently is important. Oxalate, there are certain foods that are high in oxalate, reduce that. For example, chocolate. You can do milk chocolate rather than dark chocolate, because the milk chocolate has calcium in it from the milk, will have less oxalate reabsorption. So those are the main things. And of course, referral criteria, we say if a kid has had more than one stone, strong family history of stones, multiple stones, other metabolic diseases or medication exposure that will cause them to have stones, then definitely refer them. Okay. And this ultimately, the best thing is to follow a non-lithogenic diet, increase water intake, try to avoid being overweight, increase calcium intake, moderate protein intake, less salt, less refined carbohydrates, cut back on the dietary oxalate, and more fresh fruits and vegetables. Okay, I think I will end here. Sorry to go over time. I did not realize.
Thank you, Dr. Naz. Yeah, if anyone has any questions, uh, you can either use the chat or directly through the mic. Uh, I guess we're good. Thanks, Dr. Nazia.
You want me to send this one?
Hmm?
Do you want me to send the slides?
Yeah, if you can send me the slides so I can share it with the residents.
Okay, awesome. Thank you so much.
Thank you.
Bye bye.